Dr. Haritha Gaur. So she will be presenting her paper on ocular cicatricial pemphigoid with systemic autoimmune diseases, a case series. Dr. Haritha. This one, sir. Yeah. No.
Good afternoon, everyone. This is a case series on ocular cicatricial pemphigoid with systemic autoimmune diseases. OCP is a chronic autoimmune disease marked by conjunctival scarring. The association of OCP with systemic connective tissue disorders has a synergistic effect, leading to severely compromised ocular surface, and understanding this relationship is most vital. Our aim was to report the clinical features and management outcomes of OCP with systemic autoimmune connective tissue disorders. Retrospectively, medical records of 7 patients with CTD and OCP were reviewed. All patients were subjected to conjunctival biopsy of both eyes and processed for direct immunofluorescence. They also underwent systemic investigations, including CTD profile. All of them were taken a rheumatologist consult prior to the immunomodulatory therapy. 14 eyes of 7 patients were included in this study. Mean age was 53 years with a female preponderance, and the median follow-up was 9 months. Out of the 7 patients, 1 patient had primary Sjogren's syndrome and 6 patients had rheumatoid arthritis. Out of the 7 patients, 4 of them were diagnosed to have CTD after the ophthalmic consultation. 2 of these patients were positive with human immunodeficiency virus infection. Case 1 presented with bilateral healed PUK. Case 2 had presented with bilateral filamentary keratitis. Case 3 had presented with significant fornical shortening. Case 4 had an asymmetric presentation with limbal stem cell deficiency in one eye. Similarly, case 5 also had an asymmetric presentation with central thinning and scarring in one eye. Case 6 and 7 were positive with HIV infection. Case 6 had significant surface inflammation, and case 7 is a special case which presented with bilateral corneal thinning and recurrent corneal perforations. To summarize the clinical findings, majority of the patients had fornical shortening. However, 50% patients also presented with corneal scar. The connective tissue disease presentation included findings of filamentary keratitis and healed PUK. And most importantly, aqueous deficiency dry eye was documented in 85% of the eyes. DIF was positive in 10 out of 14 eyes. However, bilateral positivity was noted only in 3 out of 7 patients. All the patients received immunomodulatory therapy with oral methotrexate and folic acid. 6 out of 7 patients, that is 85%. 1 patient who was HIV positive with high viral load and low CD4 count was not immunosuppressed. 6 of these patients, the surface was stabilized. None of them had any relapse during this period, nor adverse effects to immunotherapy. 3 line of visual improvement with a significant p-value was obtained after visual rehabilitation, with 85% cases receiving scleral contact lenses, and 28% of the eyes underwent cataract surgery. Unfortunately, the patient who had bilateral recurrent corneal presentation underwent multiple surgical interventions and ended up in phthisis bulbi in both eyes. To conclude, ocular mucous membrane pemphigoid can coexist with CTD, and a high degree of clinical suspicion is required for their diagnosis. CTD has to be ruled out, especially in those cases of OCP who present with severe dry eye or peripheral ulcerative keratitis or neurotrophic-like clinical presentation. The diagnosis of OCP has to be confirmed by direct immunofluorescence. Since the signs of both OCP and CTD can overlap, a panel of systemic investigations can help diagnose the underlying CTD. Monotherapy with immunomodulators may be sufficient in these cases to provide visual rehabilitation in conjunction with scleral contact lenses, which improve the ocular surface. Thank you.
What kind of symblophron you had encountered?
Most commonly it was medial sim left.
Sorry?
Medial sim left.
No, was it anterior, posterior, total?
It was mostly in the inferior fornix at the medial canthus.
She couldn't get to my question perhaps.
So you said there were aqueous deficient dry eyes in your patients. How did you ascertain that?
We had performed Schirmer's test to all the patients prior to any other investigations. It was done on first visit, and also confirmed after the initiation of therapy.
So was not there any deficiency of wettability or any evaporative type of dry eye?
Two of the patients also had meibomian gland disease, but most of them had aqueous deficiency.
And what about mucin deficiency?
We have not worked on that, ma'am.
But we should work because it is cicatricial pemphigoid, wettability problem could have been there. So I think you should have worked on all the three components of dry eye, isn't it?
Yes.
How many patients you have to go for surgical intervention?
Only one patient, biopsy was performed in all the 7 patients. One patient presented with recurrent corneal perforations. Every third day or fourth day, she used to have a small tiny perforation. Either we would take up for TABCL or Tenon's patch graft. She underwent thrice in each of the eye. And at the end of 3 weeks, she developed panophthalmitis and then ended up in phthisis bulbi bilateral. Only one patient had such severe presentation. We could not also immunosuppress her because she was high on HIV viral load and her CD4 count was very low, that the physician was not giving clearance to start immunotherapy in her.
Dry eye is the commonest finding you have noted.
Yes, sir.
And what is the cause of dry eye? Whether it is due to rheumatoid arthritis or due to
OCP
pemphigoid?
patients usually the incidence of dry eye is not very common. Like ma'am said, it could be mucin related. Because we found out aqueous deficiency was more common, we attribute it to the presence of rheumatoid arthritis in these patients.
Yeah.